The other thing that can happen, though, is as one's body is changing, how we absorb medications changes, how those medications work in the body or the levels in the blood can change, and how those medications are metabolized or gotten rid of by the body can change. So sometimes somebody can be on a stable dose of several medications and have done fine for 7-8 years on those medicines, but as their body begins to change, as they begin to encounter end of life, those medication doses can now become problematic. And so being able to recognize those syndromes that can occur and know which medicines tend to do it and how to scale back or adjust those doses is really important.
Welcome to the With You at Every Step podcast. We address your healthcare questions and help you navigate life's challenges. Our guests share their expertise and real-world advice related to care for older adults, grief and healing, and pregnancy and parenting. EveryStep is a nonprofit healthcare and human services organization offering dozens of programs that are there when people need us most. Learn more about our free and low-cost services at everystep.org. Thank you for listening. And here is our host, Polly Carver-Kimm.
Welcome again to With You at Every Step. Our guest is Dr. Tom Mosier, Chief Medical Officer for EveryStep. And Dr. Mosier, thank you again for being on the program.
I appreciate being here.
We always appreciate when you come on and share your expertise, especially in the realm of hospice care. I had to ask a question that actually came to me before this program. You know, anyone who has listened to some of your other guest appearances on this podcast, you give a lot of comfort and credibility and expertise regarding hospice care. If someone is in EveryStep hospice care, I know you oversee the hospice program. Do you meet with families or is that just on a as requested basis?
That's a great question. So my role is pretty vast. I'm not only in charge of all the clinical care that takes place, but also get pretty involved in each of the care plans. I do that in a multitude of ways. One of those is through regularly meeting with all of the nurses and the team, the hospice team, we call an interdisciplinary team, to review all the care plans, hear about what's going on, and give guidance and recommendations. So a lot of our patients actually choose to have their doctors be the primary doctor at the helm of their care plan. But I'm always in the background on every patient to make sure that there's areas that maybe I might have eyes for or an expertise in where I can maybe give a recommendation and give a shout out to the docs to help and assist. There are then certainly situations, not infrequently, that come up where it is requested, hey, would you be able to go and meet with the patient or family and talk to them? So I've got one of those meetings set up for tomorrow about a situation where there's some very, very specific and unique questions related to some specific medications and a disease process that is a little bit outside of the expertise of their primary doc. And I was asked to go and meet with the patient family and just kind of help guide them through that. So I don't meet with every single patient on a regular scheduled basis, but definitely am available to help in the way that is most impactful for the need at hand.
And you brought up another great point that when you are in, or if you have a loved one in hospice care, the hospice team doesn't replace your regular medical team. It's a collaboration between the hospice care and the doctor maybe that you've gone to your whole life. You work together to create the best care plan.
Yeah, absolutely. You know, there's this huge fallacy that when you elect hospice, you've come to a fork in the road where you've decided you're going to abandon modern medical care and resign to dying. And the reality is nothing can be further from the truth. What you're doing is deciding, I'm not living good enough. And it's time to aggressively use evidence-based medical knowledge and the expertise of the hospice team to amplify my current team, not to replace or throw away anything, but to literally amplify and get extra support and extra expertise towards the unique things that people face as their bodies are going through end of life.
Talking a little bit today specifically about medications at the end of life. I think as we talk about fallacies, you just sort of touched on one that we decide, and when you go into hospice, we're ending all medication, and it's just sort of drifting on towards the end, but that's very far from the truth.
Yeah, no, and I'll tell you, it's actually a multifaceted issue, because we see a lot in hospitals this misunderstanding that when somebody transitions to hospice or comfort care, that it means they need to stop all their current meds and put them on just a few what we call quote unquote comfort medications, which is frankly a buzzword that gets me hot and bothered, because there is no one medication or cluster of medications that are better for comfort than another. And in fact, if you have bad lung disease and I don't continue you on your medications to help keep your airways open and help your breathing, I would say I am not keeping you comfortable. So we want to continue those medicines. If you're a brittle diabetic and I, in error, say, well, you're dying, and so we're just going to stop these, well, you're not going to live well and thrive. So ultimately, we want to make sure that we're tailoring your care plan specifically to all of the medical conditions that you have so that you can live to the best quality possible. And we know that polypharmacy, or having way too many meds on a list, can be a huge issue for quality of life. We see it every day. So there is certainly a lot of opportunity and a lot of low-hanging fruit where we can go through a medication list and make some recommendations about, boy, this one that actually might not be helping. An example, hypertension meds, medications for blood pressure. In all of us, as we lose weight, our physiology changes dramatically. So a lot of people, when they have diabetes or hypertension, a lot of times exercise and weight loss is the best treatment for them, not medications. So when a patient has a cancer diagnosis and they're losing weight because they have loss of hunger, or the cancer is stealing all of those calories for itself, as they lose weight, their physiology changes. So we know that whereby maybe they needed 3 medications for hypertension and 2 for their blood sugars, those medicines might actually be driving their pressure too low and their sugars too low. So we know to keep an eye on that and make some recommendations about scaling back proportionate to the need. Sometimes that means we can even stop medicines, but it's not because we're throwing caution to the wind. It's because we actually know that more harm can come if we don't address those medications that maybe aren't needed anymore than the other way around.
But that brief discussion just again highlights to me we've talked about this so many times about the belief, or the mistaken belief, that you go into hospice care and, well, that's, you're drifting on towards the end. No, actually, I mean, it's got to be a daily monitoring of everything, of like weight, blood pressure, because the medications are going to change possibly due to circumstances like you just described. It's not just put you in hospice and now we just wait. There's a lot of activity going around the care plan.
Yeah, no, when we're trained in medicine through medical school, residency, or nursing school, we oftentimes don't get a lot of experience and exposure in end-of-life care. And so you only know what you know, and you don't know what you don't know. And when somebody is at end of life or dealing with a terminal illness, it is as unique of a condition as treating a child. We all know, and we're trained, that children aren't just little adults. We need to treat children differently medically. We need to use different medicines, different doses, and there's whole different diagnoses and how those diagnoses present. But at end of life, when we aren't trained and when you don't have somebody who has the training for end of life care, we often are a little clumsy because we make the assumption that, well, we're just going to treat this like we do to everybody else. And there are a lot of nuances to and changes that the body is undergoing and things that we know and are trained to be able to identify and understand that we can pick up on. So it's pretty common for somebody to come to hospice and have a startling realization that they feel better, and maybe they made a mistake. Maybe they were misdiagnosed. Maybe they shouldn't be in hospice because, wow, I feel worlds better now. Or the question, why on earth did they not figure out how to make me feel this way before? Why did I have all of this uncontrolled symptom burn before, and now you were able to get ahead of it? And it's just because we have that unique training towards dealing with those things in a patient whose body is changing and has the changes that someone might go through at end of life.
As you talk about medications at the end of life and maybe taking some away, is there any concern ever about withdrawal from a medication that is no longer needed?
Yeah, that's a spot on question. There is. And in fact, a lot of the things that we sometimes encounter at end of life, between like terminal restlessness is a situation where somebody is very, very restless. And we commonly will see people go through that at end of life. Well, we know to look for the medications that they were taking that they stopped as a cause. So ultimately, it's not uncommon as people lose their swallow, as people begin to change, to either have a medicine that was helping that had to be stopped, that we need to kind of smooth out or find a way to treat that withdrawal. And common things we overlook, just even outside of medicines, nicotine, right? If somebody was a smoker, well, we know if I make you stop smoking cigarettes, you're going to feel pretty cruddy for a while, right? And you're going to have that withdrawal from nicotine. Well, it's a very easily overlooked area at end of life. Somebody who's lost mobility and suddenly can't go outside to smoke, we need to think about replacing nicotine maybe through a patch, right? It's like a common sense thing, but it's something we easily draw a blind eye to if we're not trained to be looking for it. The other thing that can happen, though, is as one's body is changing, how we absorb medications changes, how those medications work in the body or the levels in the blood can change, and how those medications are metabolized or gotten rid of by the body can change. So sometimes somebody can be on a stable dose of several medications and have done fine for 7-8 years on those medicines, but as their body begins to change, as they begin to encounter end of life, those medication doses can now become problematic. And so being able to recognize those syndromes that can occur and know which medicines tend to do it and how to scale back or adjust those doses is really important.
What do you do for patients who are on, let's say, a number of medications that are needed, and then they lose the ability to swallow? How do you discontinue the medication, or do you administer it a different way?
It's a great question. We do have a lot of medications that we can find other routes for that are commonly used, particularly pain medications, anxiety medications, medications for psychosis. A lot of those, there are members in each of the classes that can be given by injection. And so one way to go about that is to use either IV or giving a medication under the skin called subcutaneous, sort of like diabetics give their insulin. But recently, within the last, about 8 years, another device has come out called the Macy rectal catheter. And it was developed by an amazing hospice nurse, Brad Macy. And I've had the pleasure of meeting Brad. And tell you what, every patient and family who has encountered the device that he created wants to give him a hug and a kiss. He's been referred to as an angel numerous times. When you hear rectal catheter, the first thought is, oh my goodness, that's the most barbaric thing I've ever heard. Can't we do better than that? But the reality is it's a newer device that is super slick. Patients don't notice it, it's a great way to avoid giving medications away that a patient is having trouble taking them orally, and ultimately maintain great control. So we do have lots of different ways that we can transition to if a medication is absolutely needed. An example, I had a patient fairly recently with Lou Gehrig's disease, or ALS, and they had become completely incapable of taking oral medications. But because of their disease state, they had a lot of spasticity, they had pain, they had all these different medications, about 6 or 7 medications that they were taking, that we got great control of all those symptoms that were uncontrolled, but several of them don't come in injectable forms. And so as they began to have more trouble swallowing, we started educating about the Macy rectal catheter, because that was a way that we could keep these medications that didn't come in injectable forms at the levels they needed to be at in the body to maintain control. And the family was ecstatic over how well that worked, and the patient was too. It's not that, wow, if we use a rectal catheter, thankfully the patient's comatose and can't feel it. Patients who are awake literally are so glad we recommended it and literally never want to give it up. So there definitely are things. But again, I would say if you talk to anybody in hospital care and you mention Macy rectal catheter, they will look at you like you're talking Spanish. They don't have that training and understanding. And that's why it is so critical that patients who are at end of life have the amplified layer of support of the hospice team working with them, watching over them, because ultimately it's night and day difference. The training and expertise that a hospice team has as compared to a team that is taking care of patients who are not at end of life.
I mean, yeah, a family would have no idea that even existed. I'd never heard of it till you just mentioned it. So that's another reason for the hospice team. They are full of just these, they're on top of the latest medication and medication delivery systems. It's amazing what you guys do. I want to ask you one last question here, because you talked about pain medications, and we always think of morphine as something that people always have at the end of life. Is that true? Is morphine is that just like a given, or is that not always necessary?
That's a really good question. It's a really frequently countered misconstrued assumption that when people are dying, it's painful and therefore they need morphine. It is true that if you have a condition like cancer or lung disease where you have pain or trouble breathing, it is true opioids can be a tremendous game changer in the symptoms of pain or air hunger and have a lot of utility there. And it is also true that they can be dosed in a very safe and scientific manner so that you don't overdose and don't die prematurely. There's this misnomer of that people are almost euthanized, right, with morphine. And the reality is we are trained in knowing how to use those medications in a very safe and effective way. And in fact, probably the population that most is surprised is those with lung disease. When I was trained medically, we were taught don't ever give an opioid to somebody with lung disease because you'll knock out their breathing and they'll die. The reality is the exact opposite is the case. 9 times out of 10, as we encounter people with respiratory disease, they typically die and decompensate and end up in the ICU when they panic because they can't breathe and they start to breathe faster. And that puts more load on sick lungs, which can't keep up, and they peter out. When you give them an opioid and you take away that feeling of air hunger, they stop panicking and they breathe normally, and they end up oftentimes doing way better, to the point that they may have been in the ICU 5 times in a year before they come into hospice. And then they're on hospice for many, many months with no ICU stays. And they begin to question, did I make the wrong decision? Did I come onto hospice too soon? So it's a really paradoxical thing that we see over and over, but it actually makes sense when you think about it. So ultimately, there is a time and a place for opioids, but patients who don't have a history of pain and don't have lung disease and don't have a history of being short of breath, just because their their body is going through transitioning to end of life doesn't mean that they need morphine. And in fact, opioids always have side effects, right? Constipation is a big one. And we certainly don't look at any medication cavalierly. Even Tylenol can hurt you, right? If you take it incorrectly. So ultimately, every single medication needs to have a really good reason to be there, not the least of which is opioids.
Great information, Dr. Mosier, as always. Thank you again for sharing all your expertise with us on the show. We sure appreciate it. I know our listeners do.
I'm really happy to be here. Thanks for having me, Polly.
Absolutely. Thank you for taking time to listen to With You at Every Step. If you have questions prompted by what you just heard, or you have a loved one that may need hospice care, or if you have any questions, you can contact us by going to everystep.org/care. Just go to everystep.org/CARE. There's a little form. Takes you a second to fill it out. It's confidential. It's free. And we'll get back to you to help you out the best way we can. And that is With You at Every Step. I'm Polly Carver-Kimm.